Our next speaker is Rachel Nash, and she'll be talking about hospital in the home. And Rachel is a Principal Policy Advisor in Medicine and Ambulatory Care at the Ministry of Health. Her role is managing the New South Wales Hospital in the Home guidelines and the project to manage the guidelines across the state. She's only on secondment with us, sadly, and she's normally a clinical nurse consultant in general medicine at Royal North Shore Hospital.
Thank you. Most people here will have a HITH service in their LHD. It might be called CAPAC, APAC, MAC, or PAC service. Does everybody know that they've got one? Yeah. And do you all know how to refer to your HITH service? Yeah, that's great. Okay. And raise your hand if you know what bed type 25 is. Whoa, excellent. I'll come to that in a minute. All right. So what I thought I'd talk about today is, I thought I'd just run briefly through the HITH programme and talk about potentially avoidable admissions. Obviously, not all patients with conditions considered avoidable are suitable for hospital in the home, but many of them are. I thought I'd talk about HITH targeting readmissions and how HITH can help with that, and provide an overview of the guideline and the implementation activities that we're undergoing at the moment. We're halfway through 15 roadshows, so I'll talk about that a little bit. And you've got some guidelines on the table there, so I'll talk about that in a minute. So my apologies if you've been to one of the roadshows. Some of it you might find a bit of a duplication. So I might just define what hospital in the home is. There's two types of hospital in the home. There's daily HITH and intermittent HITH. So hospital in the home services in New South Wales provide acute, post-acute and care to children and adults residing outside hospital, and as a substitution of and prevention of in-hospital care, ideally in collaboration with Medicare locals and general practice. Services are able to use both substitute and immediate prevent future admissions to inpatient hospital beds. HITH is short-term and preferably interdisciplinary, including doctors, nurses and allied health. So daily HITH, the patient is seen at least daily. Care depends on acuity and intensity of need, but is equivalent to admitted care. And these patients are still admitted into the hospital, and they're coded as bed type 25. The reason for this is because a patient that's on an inpatient ward is directly transferred over to the bed type 25 inpatient ward. Even though they're actually in the home, they're still considered an admitted patient. And sometimes it gets a bit confusing around that aspect. So that's the daily HITH, and that's the terminology we use, daily HITH. Intermittent HITH is an individual with predominantly post-acute care needs who requires less than daily clinical assessment. These patients are coded as service type 225 and are equivalent to non-admitted care. Just wanted to clarify that because not many people know that. And it is quite important, certainly important at the moment whilst we're trying to get everybody to standardise the practice and we can code and count all the patients we've got in the service. Okay, so just a little bit of background. In 2012, Professor Gideon Kaplan carried out a systematic review of HITH services, and comparing HITH services and in-hospital care. Kaplan showed unequivocally that HITH is safer and more efficient, and I've actually put those systematic reviews, meta-analysis on the table so you can have a look at those. The study analysed health outcomes, costs, patient and carer satisfaction, and showed a 19% reduction in mortality. For every 50 patients treated in HITH, one life was saved. A 23% reduction in readmission to hospital, and a 26.5% cost less than in hospital care, so it was more cost effective. Those benefits also include improved health outcomes in clinical markers such as reduced level of confusion, delirium, reduced falls, and there was a high level of acceptance with patients and carers. It also reduced adverse events. It was found to reduce adverse events, reduced admissions to hospital, reduced length of stay, and reduced admissions. So all round, fantastic service. Oh, sorry, that's too hard. Okay, so we've started recently developing a report. Our data team have done this. It's a quarterly report, and it's looking at the top 10 DRGs. Originally, the HITH services were targeting the top 10 DRGs. But we found that since the early days of HITH, the DRGs that we've been looking at have actually extended quite to a large extent, which were considered avoidable. So this is just an example of one HITH service in Sydney, and we can see that there's way more than the top 10 DRGs, and this is quite a mature service, and it extends much further than those avoidable admissions. And interestingly, this service has 15% of their referrals are directly from GPs, which is fantastic. Most patients are still referred from hospitals, though. Just raise your hand if any of your hospitals flag possible inpatients who are likely to be readmitted. No, right. Okay, the patients likely to be benefit from flagging, as you've heard already, are obviously the elderly. Patients are likely to benefit from HITH, preventing that readmission, would be the post-acute care patients with the multiple comorbidities, acute medical conditions, impaired cognition, and poor adherence to prescribed medication. I'd also like to add to this poor compliance with post-acute care instructions as well, and of course impaired renal function. So how can hospital in the home help? Hospital in the home increases available inpatient beds by providing safe and effective hospital substitution care for a range of conditions. We provide short-term, acute and subacute care, and preferably interdisciplinary. A patient can receive their care at home, residential aged care facility, in the community setting, school or workplace. All patients are risk assessed at the time of referral, and we recommend in-hours and after-hours processes to address clinical issues that the patients may have. Maybe that be a phone call, a hotline, or as such. There's different models of medical management. We've got specialist care, and that's a staff specialist, a VMO, locum, or private specialist who will accept the care of the patient. We have general practice model of care. A GP accepts care of the patient, but the GP needs to have admitting rights to be able to do this to the facility. And we have shared care, which is a combination of GP and specialist, and you might have seen this with mental health services, antenatal services, and chronic disease management service. The different types of teams we've got available are the standalone HITH teams, and this is a dedicated team of doctors, nurses, and allied health. We have their HITH integrated team, which is, it does have a dedicated team, but the difference here is we've got primary and community health as well. The advantage of this is it can flex up and down to the needs of the facility or demand management at the time. We've also got supervised self-administration, and a good example of this is in the Hunter New England, the IV out and about service, where patients administer their own intravenous antibiotics. And of course, we've got the paediatric HITH. So investment in hospital in the home is a key hospital demand management strategy and contributes to the whole of system approach to achieving NEST and NEAT. Most HITH services have systems in place to enable direct referral to the HITH service from the patient's GP. Other referrals come from the ED, consultants' rooms, medical assessment units, short stay units, nursing homes, residential aged care facilities. We recommend that it's easy, there's an easy and recognisable referral process, and it's easy to access the services as well, and it's timely, that there's no delay in accepting those patients. There should be processes in place to access HITH from chronic disease management programs, clinics and outpatients as well, if you've not got those already. So I just wanted to quickly talk about the guideline. We've recently completed the Hospital in the Home guideline. It's taken a couple of years to complete. It's been developed by clinicians and endorsed by the Ministry of Health. And the clinicians that developed this are all Hospital in the Home clinicians as well. We know that the need for delivery of acute care in the home as an alternative to in-hospital setting is being driven by advances in medicine. And we've heard that already, that increased pressure on healthcare system and evidence of improved health outcomes for patients who spend less time in hospital. So the guideline aims to tie up some of the inconsistencies so we're all talking the same language. At the moment what we've got is 67 HITH services throughout New South Wales, and we've with 3 new services about to come online in the next few months, which is fantastic. We've but all those services are coding and counting in a different way. So the actual only data that we've got is for 36 services. So you know, nearly half of the services are coding and counting, but we want all of them to be doing that so we can actually inform our decisions based on the data that's produced. We want to improve HITH service planning with the guideline, and we want to encourage local development of service delivery models. We also want to reduce some variation with the guideline as well to achieve best practice across the state and meet the needs of our patients rather than the needs of organisations. So the guideline came out a couple of months ago, and what we're doing is 15 roadshows in each of the LHDs. We're just over halfway through them now. We've still got a few to go, and we'll be finished probably by December with I think 1 LHD to go next year. In the roadshows, we're talking about the guideline contents, and we're looking at measuring success, how we can inform our decisions of hospital in the home by looking at the data, and that's consistency in data collection and measurement. This quarterly report that we've got, we're looking at the DRGs, the length of stay in the facility. We're looking at the average length of stay by state, so there's some comparison there, and we're looking at source of referral, so where those referrals are coming from, and the ward utilisation, whether the patients are coming from the ward to the hospital in the home or clinics. We're talking about activity-based funding and HITH, and this subject is generating a lot more questions than we can answer and lots of robust discussion, as you can imagine. We're looking at clinical scenario, putting it all together with a patient that's got COPD. And we're facilitating a workshop for local issues and how local services can implement the guideline and some of the challenges that exist. And with those issues, we're developing local reports and suggesting action plans on how we can help as the ministry. We're also giving out the show bags, just local information, newsletters, contacts from other HITH services, so we can start a network. And following the guideline implementation process, we'll be reviewing through a survey next year for version 2 of the guideline and what sort of content's going to be going in there. So there's a lot of issues that have come up throughout the roadshows, questions that haven't been addressed in the guideline, so we'll be able to look at those in the new year. So if you still haven't been to a roadshow yet, it'll be great to see you. We've still got another 4 or 5 to go, and one of them's in Sydney, and I think we're going to Lismore tomorrow, so if there's anyone here from Lismore, it'll be good to see you there. We've also developed a self-assessment tool which aims to help services identify areas of strengths and weakness. We're looking at the strategy, service planning and integration, decision support, and service delivery models and data collecting and reporting. And where services have been happy to leave this document behind, it's forming a basis of HITH service analysis and development across New South Wales. And if you want a copy of the self-assessment, it's on our website, so I can give you the details of that. Also, this website has a discussion board and online forum. We've got newsletters and resources there, and we're developing a frequently asked questions page because this the guideline's very new, and there's some areas that are quite grey with the HITH service when we're talking intermittent HITH, what falls in intermittent HITH, what falls in community. Some of the questions that we're needing to investigate a little bit more, and all those answers will be on the website. So we want to increase the profile of hospital in the home to patients, carers, clinicians, managers, and establish hospital in the home as a default care. We need to look at ways that promote our services. These are just a few of the ideas. We're not going to go through all these. How you may wish to promote your service. We want patients to be asking, can I have this treatment at home? And to know what hospital in the home is. Hospital in the home is a sustainable solution to patient flow, and HITH service in the future will be mainstream of healthcare, not in the periphery. In the future, all patients, where clinically appropriate, will have the option to choose hospital in the home over inpatient care, I believe. Thank you.